to join the symposium or the webinar tonight with a group of fantastic faculty that I work with at Cornell. We have Eric Alowitz, who is a spine surgeon at Cornell, who's done a lot of work on especially endoscopic minimally invasive spinal surgery recently. Michael Burke, who trained with us at Cornell and did a fellowship at UCSF, came back and does a lot of MIS deformity surgery. And we'll have two fellows who are going to join us tonight as well. Ibrahim Hussein, who's currently in Miami for 1 year with Mike Wang, who trained with us. He's going to talk about endoscopic surgery. And then Raj Nanganguri, who was a spine fellow at Cornell and just joined a group in Arkansas. He's going to present a case as well. But we'll talk tonight about spinal MIS. And I'm going to give you a brief introduction and talk a little bit about, and this is a very personal talk really, about what I consider are the main principles or the ideas behind MIS. And if you want to get into minimally invasive spinal surgery, what is it that you should consider, and where's the role of spinal MIS today? Well, if you plot the complexity of spinal surgery here on the x-axis against the invasiveness, and you start with relatively simple spinal surgery or pathologies such as a lumbar disc herniation, and you go towards more complex pathologies such as complex deformity, with open traditional surgery, the invasiveness goes up very quickly. Now with MIS, the whole idea is to dampen that curve. And that means, though, at the same time, that even though we achieve a significant benefit in the mid-portion of spinal pathologies, when it comes to really extreme deformities, I think we're still lagging behind with MIS. And for the very simple pathologies, there may not be a huge difference whether you do it with open traditional surgery or MIS. But what I consider really the benefit zone for MIS are the pathologies kind of in between, which is maybe the 1, 2, 3 level lumbar stenosis case, the case that you treat with an MIS fusion, like an MIS TLIF, for example, or a 2, 3, 4 level fusion where you do lateral approaches, oblique approaches, maybe mix them with TLIF surgery. Those, in my opinion, those are really the benefit, those constitute really the benefit zone for minimally invasive spinal surgery today. Now, but keep in mind that those pathologies make up probably 3/4 of what we treat in spinal surgery. So in terms of the volume is huge. Now, we put together this and we published this recently in the Global Spine Journal, and we call it the target, meaning really the idea of identifying the correct procedure for the correct patient. So this is really the patient selection, tools and technology, which refers to the things that we usually talk about at meetings and courses, the microscope, navigation, and so forth. And then surgical techniques. And the surgical techniques that always come up when it comes to MIS, and we'll talk about this tonight during the cases, are really the idea of being able to perform a unilateral approach for bilateral microsurgical decompression. By doing that, you preserve stability, and therefore you can treat a lot of pathologies that would usually require fusion just with a decompression, because you preserve stability in the spine and you don't have to do a fusion, especially for some of the endoscopic procedures and tubular procedures that becomes important. And then finally, indirect decompression and deformity correction with lateral or oblique or anterior approaches. Those are the 3 surgical principles, in my opinion, that come up over and over again and really form the cornerstone for MIS surgery. Now, in terms of surgical decision-making, MIS, especially with MIS surgery, the diagnosis is so important because we don't have the luxury of treating multiple levels at the same time. We want to be spot on with our diagnosis, so the history taking is important. We examine these patients very carefully. We use the help of some of the other subspecialties who are non-operative, neurology, pain management, to diagnose a patient's pathology very accurately so that we can then target it surgically with a very precise operation. The natural history of the disease is important, and then the likely impact of surgery on disease progression or on the disease process. So for example, if you have a patient with spondylolisthesis and lumbar stenosis and you do a traditional open operation and you remove a lot of the posterior elements, you may cause instability, but if you do it through a tubular retractor or with the endoscope, you preserve stability and therefore you can avoid a fusion in this patient. And again, these are really the principles, I think, where MIS, on which the MIS idea is really built. Preserve stability, bilateral decompression through unilateral approach, and indirect decompression via cages, usually from the side, from the front, or obliquely. Tools and technologies, we're all familiar with that, and I'm not going to go too much into that. Techniques, so the surgical techniques, and I find that really the most challenging to teach residents and fellows, the microsurgical technique of performing a contralateral decompression to minimize instability in these patients, and then to do a good lateral or anterior approach. Those are really the surgical challenges in the operating room, and where we really have, in my opinion, have to do a better job teaching our residents and fellows to become proficient. Again, that's the idea of performing a contralateral over-the-top decompression. There's a movie about this. I just watched that a few weeks ago. And we do that in the cervical spine as well. This is an elderly gentleman who presented with a cervical myelopathy, has terrible cervical degenerative disease, and we treated C4-5 with a unilateral approach for bilateral decompression through a tubular retractor, and this patient did very well, went home very early. There's very minimal risk of causing instability in this patient, and this patient didn't need a fusion. Especially in that age group, it's good to avoid that, as we all know. And we wrote that up. To perform a unilateral approach for bilateral decompression, especially in the cervical spine, a great technique. So we've expanded that over the years. We treat a lot of patients who have spondylolisthesis, may otherwise potentially be treated with a fusion, just with a decompression as mechanical instability. Intraforaminal soft pathology you can treat through a unilateral endoscopic approach or through a contralateral over-the-top tubular approach very safely. Lumbar stenosis adjacent to a level that requires a fusion. Patients who present with two-level stenosis, one level may be unstable. We do a fusion, an MIS fusion at one level, and then an MIS over-the-top decompression at the adjacent level. So we save one fusion in that patient. And then most synovial cysts, we decompress. We don't necessarily do a fusion. So when I translate MIS, minimal invasive spine surgery, I refer to it as minimal and measured instrumentation surgery. And I think we all know this, but we don't talk about it enough. And I think we have to really convey this message to our fellows and residents. Finally, a few words about interbody fusion for indirect decompression. I know we have obviously experts here in the audience, Neil Anand and many others, who've done so much work on indirect decompression with lateral surgery. One of the most challenging aspects of lateral surgery and indirect decompression is really to predict the success or the failure of indirect decompression. And what we've worked on and what we've published, and other groups, of course, as well, is that the presence of severe lateral recess stenosis can be an indicator that indirect decompression may not be successful. On the other hand, though, an indicator that indirect decompression will be successful is using wider cages, not necessarily the tallest cage, but wider cages. So there's some patient-related factors and some procedure-related factors that we're very well aware of that will predict the failure or success of indirect decompression. But I think much more work needs to be done so we can really advise our patients before undergoing surgery what will work and what will not work. So cage width and lateral recess stenosis are significant factors in determining the success or failure of indirect decompression. Now, deformity correction with some of the newer procedures with hyperlordotic cages, ALL release, those are all very exciting areas within spine surgery. And that has resulted in an expansion of the indication for MIS surgery for deformity correction, as recently published in JNS Spine by Praveen Momanemi, Kai Fu, and others. Now, we recently, with AO Spine, we developed an MIS curriculum that I'm very excited about. that is supposed to be able to teach residents and fellows some of the basics of MIS, how to use a drill, how to use a microscope, how to use an endoscope, and some of the basic procedures such as an over-the-top decompression with the endoscope or with tubular retractors. And we're trying to get this curriculum to be used also outside the AO, hopefully for teaching and training purposes. Now, in terms of the future, I believe that navigation and robotics are going to play a much more important role in the future. Total navigation, the idea of performing spinal fusion surgery without fluoroscopy, without having to wear lead, with total navigation from skin incision to closure. Preoperative planning is going to be more important. Augmented reality, I think, is really exciting. We'll hear today about lateral surgery, single-stage surgery. As you know, some surgeons work on prone lateral approaches, which is also very exciting, and really maximizing the ability with lateral and oblique surgery to achieve good deformity correction. And finally, endoscopic spine, and we'll hear about that from Eric a little bit more. I'm not going to go into this, but basically in terms of navigation, just for what we're working on right now at Cornell is to use augmented reality for example, for MIS T-lift surgery. So you're all familiar with using loops or loops for augmented reality. We use it under the microscope, where we look through the microscope, through a tubular retractor, we see the anatomy, and then the virtual reality allows us to project some of the basic landmarks for MIS T-lift surgery into the anatomy, such as shown here, where we can see the pedicles, the inferior edge of the lamina, the pars. So right from the start, you can see those landmarks, and you can immediately start looking for those for your surgical procedure. And we think that that improves the workflow and the efficiency in the operating room, also for teaching and training. And that's really it. I think that I want to move on at this point. I guess we have time for questions or comments at the end. It gives me great pleasure to introduce Ibrahim Hussein, who's one of our residents, who's now doing a fellowship in Miami with Mike Wang and the group down there. Ibrahim has done a lot of MIS surgery during his time at Cornell. He did a lot of work with Eric Alowitz on endoscopic surgery, and he will walk you through some of the endoscopic principles and then a case or two. Ibrahim, thank you, sir, very much for doing this.
Hi, thank you, everybody. Thank you, Ashley and Alexis, for organizing this. Thank you for the Seattle Science Foundation for hosting us. I'm giving you this talk on behalf of Eric Alowitz, we prepared these slides in conjunction with together, and he's on the webinar as well. And basically, I was going to give a quick overview on endoscopic spine surgery, and then also give a quick case presentation. And just some general background, so spinal endoscopy was really first described as early as the 1970s. However, modern direct visualization techniques and technology were first reported and published in the early 1990s by some of what we consider the pioneers of MIS surgery: Parvez Camden, Kevin Foley, Anthony Young, Jean Gestandel from France. And recently, it's witnessed a resurgence that's been concomitant with advances in technology and techniques. Even if you look over the past 5 years, there's probably been an exponential growth in the number of surgeons who are performing endoscopic spine surgery. And it's another minimally invasive alternative for some of the routine degenerative pathologies that we see: herniated disc, spinal stenosis, either foraminal, central, lateral recess stenosis. And its utility has also expanded now to other spine pathologies and indications. Mike Wang here in Miami has published extensively on endoscopic T-lifts. It's been reported for use in abscess evacuations. And our colleague, Ori Barzilai, over at Memorial Sloan Kettering, has even described it for the use in resection of primary bone tumors. The main question a lot of MIS surgeons will ask is, why endoscopy over tubular discectomy, for example? How can you improve on an already very efficient, effective, successful operation that most MIS surgeons are already very, very familiar with? And what we can tell you is that after you perform enough of these procedures, that there's ultimately, you can really see that there's less trauma to the bone and soft tissues. You do have the option of awake surgery in patients who may not be candidates for general anesthesia. You can do it through a smaller incision for whatever that's worth for a subset of patients. And I think one of the biggest advantages is really that you can have a foraminal approach for different pathologies that may circumvent the need, for example, for a fusions operation. And ultimately, I think it's going to require long-term and larger studies that really, head-to-head studies that will demonstrate whether or not there really is less recovery, shorter recovery, less pain, less dependent on narcotics, earlier return to activities, lower infection rates. These are things that I think are going to parse out over time with larger studies, but it's something that anecdotally I can tell you that we've already seen. The typical endoscope, for example, that we use at Cornell has an overall diameter of about 6.3 millimeters with a working channel of 3.7 millimeters, and that allows you to get all of your instruments through this working channel. And though it may seem very daunting and intimidating at first for your staff, your scrub tech, and even for the surgeon, I can tell you that to do most surgeries, you really need less than a dozen instruments to get the operation done. And, this is an example of one of the trays that we use of all the instruments we use for discectomy. And so you realize that with a handful of instruments, you can get most endoscopic procedures done. There are two different approaches that we typically use. The interlaminar endoscopic discectomy is an approach that you can primarily use for paracentral or central herniated discs. It does have a similar trajectory and docking approach as a tubular MIS, so it's more familiar, I think, for people who are trying to transition from tubular approaches to endoscopy. It's great for using for inferior extruded fragments, and if you're doing it at L5-S1, you can dock right on the ligament. The interlaminar space is so large that you really don't even need to do any bone removal, which is an advantage over a tubular discectomy in most cases. However, at more cranial levels, you probably will need to perform some degree of laminotomy in order to access the ligament safely. And here's an example again. The red circle is really showing kind of where the docking area is. And here, here's an example of a level where we performed a very, very small laminotomy in order to expose ligamentum flavum. And through this corridor, you can get all of your work done. It's like I said, it's great for extruded fragments. This is a patient who had a large L4-5 inferior extruded fragment in a young patient with radiculopathy and weakness. And sometimes you can actually get a fragment that's so big through the endoscope that it doesn't actually fit through the working sleeve. And you have to actually take out the fragment with the working sleeve itself. So again, these are very, very satisfying procedures. And again, you can accomplish all of the same goals as you could through a tube. The transforaminal endoscopic approach is something that I think most surgeons, again, if you look across Asia, Europe, and now North America, seems to be the more common approach. And this involves a different trajectory that most surgeons are not familiar with. Maybe the pain guys are actually more familiar with it performing their injections. But the access is really through the actual foramen itself, through Camden's triangle. And here, oftentimes, you need to do a little bit of reaming in order to open up your foraminal window. And the key thing here is that this is typically not a destabilizing procedure, even though you're reaming part of the joint out. And it's an excellent option for patients who've had prior conventional, let's say, tubular open posterior discectomy. And if you don't want to go, if they have a recurrent disc herniation, you don't want to go back through the same scar or incision as before. And you do have the option to monitor the exiting nerve root, which is at highest risk of injury with this approach. And you can do it either through an awake patient who can physically tell you whether or not you're irritating the nerve root, or with intraoperative neuromonitoring, which I'll touch on in a couple slides. The transforaminal approach, again, typically involves a cranial to caudal approach, and then also kind of a ventral to dorsal trajectory. And again, depending on the level that you're working on, the habitus of the patient, what your localizing x-rays show will show a different trajectory for each level. And the goal is really to dock. Some people have described docking on the actual SAP itself of the cranial level of interest. Sometimes what we recommend is actually docking on the posterior, superior border of the inferior vertebrae in order to actually have a much safer trajectory to perform your reaming and to make sure that you're well away from the exiting nerve. And again, here's a kind of a schematic showing where we dock on the SAP of the inferior level, performing reaming, and that allows you excellent exposure to the disc herniation inferior to the actual exiting nerve root. These are just some examples. Again, you can access even paracentral and central disc herniations through the transforaminal approach. In those situations, it does require advancing the sleeve deeper into the actual disc space itself. But again, some surgeons will elect to use this approach for all disc herniations. So it's not something that's just limited to foraminal disc herniations. And then these are just some examples of intraoperative localizing x-rays showing the docking area. And again, here you can see that our ball tip retractor can completely come around the medial border of the pedicle. And again, a lot of surgeons have described this procedure doing it awake. Again, that can have certain limitations depending on your institution, your anesthesiologist. We've recently published in conjunction with Christoph Hofstetter, who's our former colleague at Cornell, over in Seattle, about using an actual modified bipolar stimulating probe that's been modified to serve as a stimulator that helps you identify where the exiting nerve root is. And this is something that now we've done successfully without any instances of postoperative dysesthesias or neurologic deficits, weakness, or pain. So this is something that I think has been very helpful in performing these procedures on asleep patients. I have a case presentation that I'd like to quickly present, and there's a short video attached with it. But this is an example of a 71-year-old male who has extensive medical history, diabetes, multiple myeloma, BPH, presented with 6 months of severe radicular pain down the side of the left leg, really in an L4 distribution, and had gotten so severe that pretty much he was using a walker now. He had a sense of numbness and some mild dorsiflexion weakness in the left leg as well. He had exhausted multiple conservative management measures, epidural steroid injections, PT, and SEDS. And this is a patient who, again, you can see from the MRI here, has a grade 1 spondy, no significant central stenosis, but again, you can see there's a large disc herniation at the level of the foramen compressing the exiting L4 nerve root, which you can actually make out a lot better on the sagittal T2 MRIs here. On the right side, some very mild disc bulge, putting some very mild compression on the exiting nerve root. But on the left side, you can see he has significant compression of that exiting L4 nerve root. And so in these situations, again, we kind of go through the same algorithm that we would for any other patient. We think about our surgical options. An open microdiscectomy is something that could be considered. I think most people in this forum who are familiar with MIS approaches would not err towards this option. A tubular discectomy is something that I think most people would consider. You could either do it through an ipsilateral traditional approach, or really for foraminal pathology, again, Dr. Härtl has described this extensively before about doing a contralateral approach, kind of doing your unilateral laminotomy, coming over the top to get a more straight trajectory towards a contralateral foraminal pathology. A far lateral pathology is something that you could consider. Again, this isn't really a far lateral disc herniation. Some people may consider this. I think most people in the forum would agree that this probably isn't the best option. A transforaminal endoscopic discectomy is something that could be considered. And this patient, in fact, I think had other opinions from fellowship trained spine surgeons in New York and was recommended for an MIS TLIF given the spondy and again, his focal foraminal disc herniation, with coming in from the left side, doing a facetectomy on that side. I can tell you that he didn't have any dynamic instability on flexion extension x-rays. And so, again, we go through the same algorithm, and again, we consider all different options, but it's always, Dr. Elowitz's algorithm looking at this patient. These are any of these procedures he could perform. Considering it's a sick patient and you really have a focal pathology and you want to perform the least invasive surgery possible to try to address his pathology, with the patient understanding that he may require another operation down the road. Ultimately, this patient had elected for a transforaminal endoscopic discectomy, which is one of the best options that we had recommended. I can show you really quick. These were the intraoperative localizing x-rays we had used. Again, you can see the grade 1 spondy. And again, you can see kind of our docking area. It's not really on the SAP of the inferior level of interest, but really on this posterior superior corner of the vertebral body. And from here, I can switch over to the video. So as soon as we get down, put our working sleeve in and start working, we almost run into immediate disc material. There's some soft tissue that's here as well. We use a bipolar cautery probe to try to shrink back some of the fat and soft tissue. We then come in with a rigid ball tip probe to try to help identify where the exiting nerve root is. And again, cranial is on your left side of the screen. Then we come in with our stimulating probe, which shows that we have a positive response on the left TA, which shows that our exiting nerve root is on the cranial side on the left side. After that, we turn our sleeve 180 degrees, and now we have our exiting nerve root protected, and we can really go to town with our pituitary performing our discectomy. After we turn the sleeve back around 180 degrees, we inspect the exiting nerve root. And again, we try to trace it out laterally as far as possible to make sure that it's fully decompressed. And we'll come back in with our stimulating probe just to make sure it's freed up. Also to make sure we continue to have a signal from our IOM team. And then again, this is again just a double, triple check that we have excellent decompression of the exiting nerve root, as you can see here. This patient ultimately went home about 3 hours after surgery. We followed him up. After 2 weeks, he has complete resolution of his radiculopathy, off narcotics, back to his usual activity, daily activities, and really hasn't had any other further issues almost a year plus out in terms of worsening spondylolisthesis or recurrent disc herniation. So again, this is just an example of a case where we were able to successfully perform transfemoral endoscopic discectomy, as opposed to a tubular approach or a T-lift, which is something that I think a lot of surgeons would have possibly considered. And that's it. I think this case we'll save for the end. I think Dr. Härtl will go back to maybe Raj or Dr. Brick's case.
Ibrahim, that was great. Thank you so much. It's always great to have someone present endoscopy who actually was trained with surgery, with real surgery. They can explain it in a way that us non-endoscopic surgeon can actually understand what they're talking about, which is great. And Eric, I'm sure, is going to talk about this later. We'll go on with Raj Nangunori. Raj was a fellow with us, and he's going to present a case.
Thank you, Alexis and Ashley, as well as the Seattle Science Foundation for having me, as well as Dr. Härtl for the invitation. It's an honor to be here. I'm actually going to be talking about one of our cases that we did while I was in my fellowship, which I just completed. I'm not sure if my slides are up yet, though. Okay, let's see. All right. So I have a case here. Give me 1 second. Let's see, there we go. Okay, good. Okay, so we have a case here of a 77-year-old male physician, chief complaint of back pain and left leg pain for about a year, worse with ambulation. Really couldn't walk. He was pretty severely disabled due to his left leg pain. In addition, in the office, as Dr. Härtl mentioned, we do a pretty thorough physical examination. We did a provocative maneuver called the Kemp test, where we have the patient stand up, extend back, and flex to the side of the pain and reproduce some of his radiculopathy. And that's usually a good diagnostic indicator that there's a certain nerve root specifically that's being involved, especially when you look at the imaging studies, which we'll look at in a second. He does have a history of a L3-4 laminectomy infusion at an outside facility without an inner body about 10 years prior. He did have a mild mechanical back pain that was worse with movement, but really his chief complaint was, as described, was the leg pain that made it difficult for him to ambulate. He had tried a number of conservative treatment options, all of which failed, and also tried a bunch of neuropathic medications, which were not very effective. On exam, he was neurologically intact with no weakness. So these are the representative MRI images, as you can see here. This is a sagittal T2 weighted MRI sequence, as well as an axial. The axial view is corresponding to the L4, L5 level. As you can see here, you see kind of the artifact from hardware at L3, L4. You see the severe disc degeneration at L4, L5 with the spondylolisthesis, as well as severe disc degeneration at L5, S1. In addition, specifically with the spondylolisthesis, there's a degree of a rostrally migrated disc fragment, and there's also evidence of central and lateral recess stenosis. This is another view here. Sorry, going back. Another view here. The left is a T1 sagittal image, and then the axial is corresponding to that cut on the on the parasagittal view on the left side, demonstrating that below the L4 screw, you can barely see the epidural fat, which we normally do expect to see if there is no nerve root compression. Here, you can barely make out the signal of the L4 nerve on the left side, suggesting that his symptoms, along with the provocative maneuver, were pretty indicative of his pathology. In terms of his actual vascular anatomy as well, anytime you're considering a procedure on a patient, if you're thinking that you need to do a foraminal decompression, I know some patients, as Dr. Hussain mentioned, would benefit from an endoscopic approach, but given the degree of disc degeneration, which was pretty far advanced in this patient, but we also considered the other options, anterior approaches such as ALIF, as well as lateral inner body fusions as well. These images are to represent the vascular anatomy, which basically made the anterior approach suboptimal because of the way that the multiple venules are essentially dilated over the disc space. So as a result, the anterior approach was not considered for this patient. This is a CT scan, again, demonstrating the fusion mass at L3, L4 on the right and the left sides. You also have vacuum disc phenomena at L4, L5 with the spondy, as I mentioned before, as well as at L5, S1. Flexion extension views did not show any dynamic instability. However, you can see the spondy here pretty clearly. We also routinely get scoliosis x-rays because we want to evaluate the patient's global sagittal parameters and make sure that we're not creating a deformity. In this case, this patient had a mild sagittal deformity. He had a mismatch of about 18 degrees with an SV of 6, which is within normal range for his age. And so while this wasn't a deformity operation, we always like to keep those considerations in mind. So in terms of the surgical options, the options that we consider were decompression only, decompression and fusion L4, L5, whether to include L5, S1, anterior approaches. So there are a number of considerations, but given his vascular anatomy and the degree of pathology at L4, L5, as well as the concern that he would degenerate L5, S1, we elected to perform a revision procedure, doing an exploration revision of the L3, L4 instrumentation, all done minimally invasively with the L4, L5, L5, S1 TLIF, again, with MIS and tubular retractors, with a total laminectomy, as Dr. Härtl showed in one of the earlier slides. You can do a nice over-the-top decompression to decompress bilateral lateral recessed regions. And we instrumented from L3 to S1 with total 3D navigation. And we use navigation for pretty much every step of the case, from pedicle screw placement to the tubular decompression, placing the tubular retractors. So in terms of total navigation, as a result of using the intraoperative CT scanner, we can limit the skin incision, plan the screws, place the retractors, as well as do the decompression and cage placement. In addition, we can also do a post-operative check to make sure that we have adequate decompression, as well as to check the position of the cage, as well as the screws. And Dr. Härtl mentioned some of the other indications as well here. And we also published, as well as other groups, a number of articles about using 3D navigation. Various platforms are in effect. The one described here, you can see here is pretty much, you have an iliac crest reference frame, and essentially you can navigate the screws as well as use a graphic to demonstrate the cage placement as well. This is a picture, representative picture of the intraoperative CT scan that we use at Cornell. And the patient is taped securely to the table in order to facilitate navigation. For concern that if the reference array is moved or the patient moves, you can have inaccuracy. So patient securely padded to the table.
Hey, Raj, I think that's right. Raj, it's Roger. Maybe we should, I think that was a great presentation. Maybe we should move on with Mike so we don't run out of time.
No problem.
Is that okay with you?
Yeah, that's fine with me.
So next we have Mike Verk, who's going to talk about single stage surgery. Mike trained with us. He did a fellowship at UCSF and came back to do deformity and MIS. So thanks, Mike, for being here.
Great. Hey, thank you, Roger. Can everybody hear me? Great. Okay, so thank you to the folks at Seattle Science Foundation. Thank you for having us, and thank you for hosting our institution. It's great to interact with you on the West Coast. This is I'm just going to run through a case. I'm not going to do a whole bunch of didactics here, and hopefully some of the main teaching points will come through in that in our review of it. Great. Okay, so. Sorry, 71-year-old gentleman. He presents to clinic, and this is all outpatient. Back pain. He's got radicular pain in multiple distributions, anterior lateral as well as posterior. The right is worse than the left. He's got burning numbness and paresthesias from the mid-calf to the toes bilaterally. He's got dense numbness in his feet. He does say that his back pain is worse than his leg pain, and notes that his numbness begins immediately upon standing and is consistent while he's in the vertical position, walking, and is only relieved by sitting. He's able to walk about 1 block at this point due to a combination of numbness and pain. He's neurologically intact with respect to strength. He does have he has some persistent numbness in his toes in the L5 distribution, but for the most part, his sensation is intact and his reflexes are normal. So just look at some of his pre-op imaging. This is an MRI. On the far left, we have a parasagittal, and then or mid-sagittal, and then the left a foraminal shot here where we can see that the foramen look fairly patent for the most part. So he does have central stenosis at 3-4, grade 1 spondy at 4-5, spondylosis at 5-1 with a disc bulge. On the right side, through the foramen, we can see that he's got pretty considerable modic end plate changes, fatty replacement. He's got the 3-4 foramen is at least moderately stenotic. At 4-5, he's got a large disc protruding up, the uncovering of the disc with some extension into the foramen, causing severe exiting nerve root compression. And 5-1 foramen is tight as well. His axial cuts, 3-4, 4-5, severe stenosis. Significant arthropathy at 4-5 at the level that he's got the spondy as anticipated. And 5-1, he's got a disc herniation, eccentric to the left, lateral recess stenosis. The joints look okay there. Here's a CT scan. You can note the osteophytic growth, consistent with his mild coronal plane curve. He's got vacuum phenomenon. Retrolacesis of 4-5, anterior lacesis of, 3-4, anterior lacesis of 4-5, and then some sclerotic end plate changes. Things to note here is air in the joints. We also saw the bright T2 signal there. Those are really nice joints. You can get some good distraction with when you see that morphology. We see that, here he's got this large superior articular process riding up into the foramen. Also, do we tend to see this in spondylotic patients or patients that have up-down cranial caudal stenosis? So in terms of how to treat these patients, I think this gives you a considerable amount of information. Flexion extension films. It's got a little bit more retrolacesis at 3-4 when he extends. Nothing radical here, a couple millimeters. We can see his coronal plane imbalance, long cassettes. This guy's pretty well balanced globally. This is, SVA is essentially normal for a 71-year-old. He's got good lordosis to match his pelvic incidence. So from that standpoint, he looks pretty good. So there are a whole bunch of options. I think the critical element here is to identify what's wrong with the patient, what's causing his symptoms, and his symptoms are neurogenic claudication, right side radiculopathy in L3 and L4 distributions for the most part, severe back pain. These are his primary. He's kind of got the the global lumbar package with respect to his symptoms, and he's got the imaging that I think corresponds to his symptoms. So in terms of what we're thinking for treatment, 3-4, 4-5, plus minus 5-1, depending on how appropriate you think these are. But he's having direct symptoms directly related to L3-4 and L4-5 pathology. So with respect to some of the options, this when we could say single stage, it's really just a combination of multiple techniques that I'm sure you're all familiar with. It's an anterior approach, it's a lateral approach. Whether you go trans-psoas or pre-psoas, I don't think is, there's a lot of nuances and subtleties that we can debate, particularly for the aficionados. But primarily, we're taking an anterior approach to the 5-1. It's a retroperitoneal approach. When you put a patient in the lateral position, you can do a somewhat oblique incision. It's drawn out here. I do this with a vascular surgeon for all the 5-1 approaches, whether I go anterior or oblique like this. But what's nice about this, what he always mentions to me, this is Sharif Alozi. He's one of our vascular surgeons. I do all my anterior surgery with him. He's fantastic. But he always notes that he just has to do less retraction because the peritoneal contents really fall out of the way under the influence of gravity. And for him, it's a much easier approach with respect to putting in the retractor. So he really likes it. And then we're already set up for whatever type of lateral approach you like to do. One thing with this, extremely important to secure the patient. We can talk about a little bit about image navigation. You've got a lot of options for this. You can use C-arm reconstructions, systems like the Zeem. You can use an O-arm. You can use an intra-op CT scanner like the Aero. There's all types of options that are appropriate for this. It really depends on when you make the transition to doing this type of surgery, just use the thing you're used to. And then you can go from there. For me, with lateral surgery, I prefer to use real-time imaging. I like fluoro. I'm a huge navigation guy, big believer in neuronavigation. But for lateral surgery, particularly multi-level, I do prefer to do this under real-time. So here, this is the vascular surgery team obtaining access through this incision here. We basically use the fluoro just like we do in a lateral case. Here he is with his exposure. It's extremely comfortable from a surgical standpoint. You actually get to do this seated, which is really nice. I don't do too many cases where I can sit down, and this is one of them. So at least for the 5-1 level. So we've got a lit retractor in here. We're exposing the space, and essentially we go through our normal workflow for any sort of anterior lumbar interbody fusion at 5-1. You can get in there with large angled cobs, do a beautiful anterior longitudinal ligament release, get deep, do a massive discectomy, expose the end plates really nicely with great care so that you've got good surfaces for arthrodesis. You can put in whatever cage you want. Again, we are not trying to recreate lordosis here in this patient's lumbar spine. We're certainly trying to keep from creating a flat back scenario. So we're trying to get, the goal here is to get take advantage of indirect decompression, but still maintain our spinal pelvic parameters by accessing the interbody space. So here we have 5-1 going in, and then we make our transition really seamlessly right to going lateral. I prefer a trans-psoas approach. Again, I don't think that it matters too much what you're comfortable with. And by this method, we access 3-4 and 4-5. Again, fluoro versus navigation, I think it's dealer's choice here. I like to do navigation simply because these graphs are so powerful. You're changing the spine a lot. Things are moving, and your navigation goes off at every segment. Now, in the era of segmental registration and just taking x-rays to reconfirm your navigation, that may no longer be an issue, but we don't have that capability quite yet. We will soon. But for right now, this is how I'm doing it. With respect to neuromonitoring, I think if you're using a trans-psoas approach, you're absolutely need to be aware of where the lumbosacral plexus is. You need to know where those nerve roots are when you're coming through the psoas. So we're very dependent on that. It's extremely important for us to use. So we do use it. At the end of that, we get these graphs in. This is what it looks like. To critique this is my case, but to critique this here, I would say that ideal placement of lateral cages spans the end plates. You really want to max them out. It's fine to get on the osteophytes, not necessary, but I could have made this a little bit longer. Always use 22 or 26 in width. I think Dr. Härtl touched on that earlier. We just see less subsidence, and we're really dependent on these interbody spaces for our arthrodesis as well as for our indirect decompression. So if you have a lot of disc space collapse, you lose your indirect decompression, and you're set up for a pseudo because you don't have a fusion mass put in a posterior lateral compartment. So really important to observe a lot of what has been published and what a lot of the guys who have come before me have talked about with respect to how to optimize these cases. And now we just go on, and I want to thank Dr. Härtl, who always does a great job of documenting some things. I borrowed a bunch of his slides for the lateral. This is just a percutaneous screw insertion with neuronavigation. So nothing fancy here. The array goes into the iliac crest. We've got the patient taped. Now remember, you're not using a Jackson table, so you don't have the benefit of harnessing gravity to create your lordosis or to at least facilitate getting the patient into a lordotic position before you lock them in. So you've got to be aware of that. That's always a critique of doing this type of case in a lateral position. But I think that if with some good positioning, securing the patient, using optimal size grafts, and contouring your rods properly, if you need to, you can do some facetectomies. It's a little bit more difficult in the lateral position to get the offside facet off. Okay, so just things to be aware about, some of the details. So we go through here, we plan our incisions. This is a single stage navigated screw. It's basically replacing your Jamshidi, your K-wire, your tap, all in one. There are several companies that have these systems now. You basically get cortical purchase, and you put the screw directly in under navigation. So it's a really seamless way of getting screws in. I will say I do use pedicle preparation sometimes in the lateral position because I don't like to put as much pressure onto the screw. The patients move a little bit more when they're not on a Jackson table. So using either a navigated all-tip tap or a navigated drill guide is going to help cannulate and prepare your pedicle, and you can come right behind that with the screws. Okay. If you do need to do a decompression, in this case, I did do a 4-5 facetectomy just to be sure about that, about the decompression there. It's very easy to get tubes in on the upside. Okay. So getting in, docking a tube under navigation, going through your standard dilation protocol, confirming microscope, very easy. Dr. Härtl mentioned over top decompression, very easy to do in the lateral position. You can come all the way across as you normally would, see the ligamentum flavum, take it down on the contralateral side, do a total facetectomy, laminectomy, whatever you think is necessary in conjunction with your indirect decompression. It's just a belt and suspenders sort of maneuver. And then you pass your rods, you lock them in it's subfascial fashion. And these are our standing films. Here's our post-op measurements. We've essentially preserved them, maybe given him a little bit of lordosis. These are his initial post-op films. Things always change a little bit, but that's how he looks right now. If anything, maybe a little bit overcorrected. I was trying to keep him exactly the same. Just take care of that up-down stenosis, the cranial caudal pedicle based stenosis, and 3, 4, 4, 5 in the concavity, and then decompress his central stenosis and get a good arthrodesis. Those are the goals of the surgery, and I think that this technique is one option for accomplishing them. And so I think that's it. Thank you very much.
Mike, that was great. You know what? I feel terrible. I rushed Raj, my fellow, and he didn't show the post-operative x-rays. So if you don't mind, before we move on to questions and comments, if we could go back, Linda, and have Raj just show the post-operative x-rays, because there were so many other slides in there. I just wanted to.
Is this the one you're looking for, Dr. Härtl?
Yeah, this is the one. Yeah, I mean, basically, this was the post-op. This was the post-op 2-level T-lift that we had done. As you can see, there were really no changes in the coronal parameters. We didn't perform an anterior or lateral approach, but we did bring his SVA down by slightly. In addition, we reduced his mismatch to about 9 degrees. More importantly, other than just matching up the numbers, clinically, the patient did very well with the 2-level T-lift, given the fact that we couldn't do like an anterior approach. Let's see here. I don't know why it's not moving the slide. There we go. These are again the post-op images. You can see pre and post-op here. Really good result, and the patient was doing extremely well post-operatively. 2 weeks, his left leg pain was gone. He was back to seeing patients in the office. So really a great outcome for him. So he did really, really well.
So maybe we'll open it up for questions, comments. We've got a bunch of questions in the chat, but if somebody has a particular question, there was a question about the biologics for Michael Verk. What type of biologics do you use for fusion?
Yeah, I'm pretty conservative with respect to biologics. I think in closed channel, anterior approach with the interbody cages where you're leaving the posterior annulus intact and the lateral annulus intact, I do use BMP in those cages. And that's consistent with what it was approved for. The indications for BMP are likely going to expand simply because people are using it more. I just tend to use it like in that fashion. I use titanium mesh cages for the lateral approaches, and I use allograft in there with some plus or minus undifferentiated cells cultured onto them. We're looking at that in some long-term studies to see whether or not that makes a difference. But fusion rates for the laterals have been extremely high, and I really haven't been tempted to use BMP there. Posteriorly, I do not perform posterior lateral fusion on that particular case. Now, in several circumstances, I will go back there and decorticate the joints and do other things to facilitate fusion posterior laterally. But for the bread and butter degen case or very minimal deformity, I feel comfortable doing that.
Hey, Michael, that was a beautiful job you did in that case. How long did it take you to do that?
Well, I think that was probably my first or second case. So that took me a little bit longer because I was still trying to figure out the ergonomics and the workflow and what kind of adjuncts. We're very fortunate to have a few different types of imaging systems, and I was worried about bringing in the Zeem because the big flat panel kind of gets in your way. And now I've gone towards using that a lot more. I've cut down time there. That took me a good six hours or so at least. You know, I mean, it took me a long time. That was the first time I'd done that.
So what do you think your learning curve was, and what can you do? How fast can you do that case now? And I know each case is different.
It's getting a lot faster. I've probably shaved off on an L2 to S1. I did in 6 hours last time, which was a much more complicated case, and that was pretty fast for me. I definitely don't tout myself as I'm not a speed surgeon. You know, I spend a lot of time in all these cases. I'm never going to set any world records for speed. But that's about how long it takes and I think this case really shines L3 to 5, L3 to S1, where you can really move quickly. What I think the difference is the patients, they just don't experience the same amount of postoperative pain. They're a lot more mobile. I don't transfuse any of these patients. Blood loss is extremely low. I've just cut it down by not doing any osteotomies or major facet work. It's just cut down a lot on the blood loss. We lose very little blood on the anterior approach. As long as we don't have a problem at 5-1, we tend not to have any problems there. Sometimes the iliolumbar we always get, but it's the middle sacrals can give you a little bit of trouble, just like in a standard ALIF. Sometimes those can be tricky, and we can get a little bit of blood loss there. And of course, if you get into a big vessel, you're gonna lose some blood. But I think that those are the reasons that the patients are able to get out of bed on day one. Now, out of 7 or 8 of these now, the vast majority of patients, I'm doing them on more frail patients as well. They're just able to get out of bed and ambulate much faster. And I think that it's a combination of pain and blood loss. And we're just not transfusing these patients.
There was a question, actually one question from Jens about the economics of endoscopic surgery. Eric, you saw that,
I did. Yeah, I saw that. And I think you're right. Value in spine is important. It's something that there'll be more attention to, and cost benefit analysis for endoscopic surgery really needs to be looked at. But I think we also have to consider that some of the other benefits of the endoscopic surgery, as Ibrahim talked about, transforaminal approach, which is really not something that we could replicate with tubular approach, and avoidance of fusion, no bone removal L5S1. So I think there are some concrete differences. Whether these are worth it in terms of cost benefit, we'll have to see over time, but I certainly believe it is.
A few words about DRG injury and learning curve for those of us who may want to pick up.
DRG injury is certainly one of the big concerns with the transforaminal approach, and that's why many surgeons opt to do it awake. We do it under general anesthesia, but with neuromonitoring. Ibrahim talked about the steroid stimulation. We also have free-run EMG. I have to say that in probably about 100 cases, we've not seen any DRG injury, have not even had any stimulation of the DRG. So by keeping a safe trajectory to stay low in Cameron's triangle is really adequate to prevent injury to DRG. Other question about learning curve, it's new. To me, I think it was easier to do, at least to start with the interlaminar cases, because that's already an operation, an approach, anatomy that I was already extremely used to, and then just get comfortable with holding the endoscopic equipment. And then I moved and transitioned to transforaminal approach. But I mean, there are many endoscopic surgeons who would argue just go straight into transforaminal. But no matter what you do, I think spending time in the lab with cadavers is really important. And it really, unlike a lot of other surgery, cadaver work really replicates what you see and feel in the operating room.
Where do you see this going, endoscopic surgery, in 5, 10, 15 years? What is it going to replace or improve other than decompression or what you presented?
I think there's a lot. I think fusion with newer techniques, with disc plate preparation, different types of implants that are being developed. So I think fusion, number one. I think indications for thoracic discs and cervical are also being expanded. I was just asked today by one of my colleagues if I could do tethered cord releases with endoscopies. I don't think right now, but I can see probably in the not so distant future, we may be doing that.
Eric and Roger, these are really exciting techniques. And I was fortunate enough to train with Parvis Cambin when I was a resident. And it was very, very primitive and very crude compared to what we have today. What do we need to do today to get the residents exposed and to really promote this? Because this really is the future. I mean, there's no question. It's the learning curve that I think scares away a lot of people in our generation and even younger generations. They don't want to spend the time. They don't want to do it. They're looking to do the fancier cases that maybe get reimbursed more. But this is the wave of the future. There's no question. So what do you think we can do to try to help promote it even more?
I think forums such as this to discuss it. I think one of the problems with endoscopic surgery was that it was kind of viewed initially kind of as fringe, something that mostly pain management doctors were doing. A lot of sort of respected spine surgeons were not doing it, and those surgeons who were respected were, very independent-minded. But I think bringing it into the academic sphere, literature, books, courses, more faculty doing this and bringing this to our residents. And I can tell you that in our program, residents often will fight on doing these kind of cases with me because they're really enthusiastic, they're really excited, and they also agree this in the future.
Yeah, and sent your residents, fellows to learn somewhere, to pick up some, Ibrahim, who trained with us, he's spending time with Mike Wang. We have fellows that obviously come to our institution to pick up MIS, and part of it is the curriculum. We worked with the AO on a curriculum to really kind of break it up in piecemeal, 10 steps for every procedure, teach residents, fellows how to use the drill, how to use the microscope, how to use the endoscope, and then integrate that into courses.
Roger, you still using the model that you helped develop with the AO for teaching, and how are the metrics within that teaching system translating into clinical expertise?
That's a great question. We've been using the and there are other companies as well. It's called a real spine, the real spine model, where you can do an endoscopic or a tubular decompression in a situation where the anatomy matches the real anatomy almost 1-to-1. It's pretty amazing to operate with these models. And we just published, or we submitted a study where we did it 3 times in a row. We broke up the procedure in like 25 steps, the tubular over the top decompression, and had surgeons do it 3 times, like residents and fellows, 3 times in a row. And then we measured the metrics over those 3 surgeries in terms of timing, errors, CSF leaks, mistakes. And you can see that they get better every time they do the procedure. It's actually a really fascinating paper, in my opinion. So that shows you. I mean, you got to break it up in steps. You got to do it, and then you got to critique it and have them do it over and over again, and they get better. So that's one way of integrating these models into surgical training.
Yeah, which is a wonderful step in education, having some real objective metrics that you can measure.
Yes, yeah.
This was